um, and we're just basically going to talk about the changes from DSM-4 to 5, and how sort of DSM-5 is set up. Of course, it's a big book, so you'll gradually learn over the period of time when you talk about individual disorders. So, what is phenomenology? What do you understand by phenomenology? Any idea? So, phenomenology is a strange word that they use, because it's the meaning of phenomenology historically is related to like philosophy and psychology and things like that, and it has nothing to do with what they say it is in DSM. In DSM, it's about the signs and symptoms, you know? And in the history, it's about the study of phenomenon, different kinds of phenomena. But somehow, in psychiatry, they describe it as the signs and the symptoms and the psychopathology that we deal with. So it's something that you probably don't need anything clinically speaking, but this word is there in DSM-5 a lot when they talk about signs and symptoms. They say that this is the phenomenology of the disease, and so it includes the signs, it includes symptoms, it includes their thought processes, their emotions. So, like I said here, I mean, even descriptive psychopathology is known as phenomenology, but it's sort of a misnomer for that. And if you go to some other definitions, it also is supposed to be the basis of nosology. What is nosology? Nosology is basically study of diseases. So phenomenology is supposed to be what nosology is based on. So when you develop the definitions of diseases and diagnostic categories, and you call it phenomenology. So when they started the DSM, in the beginning there was DSM-2, which was very sort of descriptive, based on the older psych models like the psychoanalysis and based on the defense mechanisms. And then when they came out with DSM-3, that's when they started this axis. And I mean, they weren't really trying to do anything special, but somehow it became sort of an instant hit. It became sort of a revolution in psychiatry. I mean, they say the copies that they printed sold out within 6 months, and then they didn't know what to do, so they had to print it as a back order, because DSM-3 became instantly hit with the psychiatrists and the clinicians when it came out early. So that's when all this focus on the DSM started. It says DMS, it's DSM. And DSM-3 was used widely until they moved on to DSM-4, and then there was DSM-4 TR, text revision, which is what we used when we were training, and which is what you used when you were a student. So what is DSM? It's Diagnostic and Statistical Manual of Mental Disorders. The goal is to make sure that we have more reliable diagnosis. It's supposed to be a very practical guide, very functional guide. It sort of organizes information in one place, and so that we can treat the disorders better. It's supposed to be very concise and explicit, which I think it is in a way, concise and explicit. So it's supposed to give us an objective assessment of symptoms. That's why the checklist kind of psychiatry has come in. Before we trained, or even much earlier than that, psychiatry was based very much in the psychodynamic world. The Freud and other people dominated the thought process of psychiatrists, and there were terms like neurosis and hysteria that were used. and based on that, they would sort of descriptively talk about the patient. But this sort of gave a little bit more objective assessment of the patient based on the symptoms in different clinical settings. So it was sort of a revolution when DSM came out, and we could sort of collect the records based on one specific sort of assessment tool, rather than having different philosophies in psychiatry. You know, some people believed in one school of thought, others believed in other school of thought. So there was a lot of vague diagnoses, but this made it more accurate and more organized. So it became sort of a tool for collecting all the information, and gave us more information on the diseases, on mortality, morbidity, and of course, for the students, when you start off, DSM is very essential. I mean, you should try to read it as often as you can, because this should become sort of natural to you. You shouldn't have to remember what's written in DSM. It should just come to you, when you ask the signs and symptoms. And the way to do that is to read it more often, to make sure that you don't have to think when you're asking the patient. You shouldn't be thinking about criteria. It should just flow when you sort of do the interview. So with DSM-5, they made some changes in how the chapters are set up. That they begin with disorders of childhood, go on to teenage years, and go on to sort of young adulthood, and later on the middle age, and finally talking about the neurocognitive disorders in old age. So this was thought to be a better way of presenting the symptoms and the diseases than what was previously done in DSM-4. And I think it's smart. It also makes it easy to sort of remember stuff, and that's how it's sort of set up to give a lifespan approach. Even within individual chapters, that's how they're organized. So that's one change from DSM-4. And then they try to integrate information from all the research that's happened, including the risk factors and the prognosis factors, because we have learned so much since DSM-4 came a long time back. And they've also talked about some diagnostic markers that are new in psychiatry, and so it's sort of a little bit more scientific than what was in the past. And then the integration didn't happen just because they just put it in there. They did their field trials to look at different diagnoses based on those factors, because before they put the diagnosis in, they selected certain areas where they did field trials for the new sort of diagnosis they were going to give. And based on those field trials, this went on for many years before they came out with DSM-5. And so it's been going on ever since I think I was probably came out of training. They've been talking about DSM-5, and then it gradually came out. Even before, I think when I was training, they were talking about DSM-5 then in 2005 and 6. So it took them many years before they did this revision. So what changes have been made? They've moved from the axial system. There's no axis 1, 2, 3, 4, 5. So as you probably already are aware, we had the main diagnosis in axis 1, and then the personality disorders and intellectual functioning disorders, and some V codes in axis 2, and then axis 3 was there for the medical reasons, and axis 4 was for the psychosocial factors, and then finally you had this GAF in axis 5, which wasn't really useful. There was sort of, people would just pick up whatever GAF they wanted to give, So In the hospital, we usually would give like 10 to 20 of GAF and 20 to 30. And then, if the outpatient, people would get a GAF of 40 to 50 to 60. So it just depended on how you thought about the patient that you would get the GAF. And there was some usefulness in some insurance companies sort of deciding when they needed admission, but that sort of became a game. You just put it accordingly, the GAF that you thought would benefit the patient the best. So they've gotten rid of it. They have this WHO disability assessment scale, which we don't have to really do, but it could be included in the future DSM or even the revisions of DSM-V, because it's in the section 3, which deals with future changes in DSM-V. So these things have basically changed, and then there is more consolidation of these disorders. So they've clubbed autistic disorders and Asperger's and PDD into one autism spectrum disorder, which makes it more homogeneous. Since basic symptoms are the same, it improves the sensitivity and specificity of the diagnosis. There was too much, maybe some overdiagnosis in the past, or many times underdiagnosis because of lack of clarity. And this can help us develop more treatments focused on the same kind of disorder, rather than focusing on different treatments for autistic disorders, different Asperger's, because essentially they're the same. The main problem is in the social communication and the repetitive patterns, and the difference, as you know, is in the IQ between people who have Asperger's versus autism. And that's one main change. And then there's the second big change is in the substance use disorders. So in the past, all we had was like alcohol abuse, opioid abuse, opioid dependence, and it wasn't very clear, what was abuse, what were dependence, and there was no clarity in terms of how the diagnosis was made. As a psychiatrist, you could do it because you have to deal with this a lot. But for the non-psychiatrists, they would know whether it was abuse or dependence, because the diagnoses weren't as clear as they should be. So now we have just the use disorders, and it also helps clarify for people, or makes it less of a stigma for people when you tell them that you have addiction. They don't like it. Dependence is maybe different from addiction. Addiction is if you go out and seek drugs. So dependence can also be because you have been on something for a long time, and then you probably have developed increased tolerance for a substance. People who here. So, there are people who are on pain medicines for a long time. We have people who are on benzodiazepines for many, many years. They started with a low dose and they have gradually increased the dose because they develop tolerance for it. And if you try to get them off the drugs, you have withdrawal. So that sort of meets the criteria for use disorder that they have in the new DSM-V. So one of the goals was to avoid that stigma that had associated with it. And then they streamlined the bipolar disorders and depressive disorders into one main mood disorder spectrum. And even the cognitive disorders have been streamlined a little more. And they've developed a new model for personality disorders. That one model is still there that we originally had, but they've come up with another new hybrid model that once you read, you will get to know more. So they made changes in most of the main disorders. And same thing has happened with psychotic disorders. They made the schizophrenia less complex. You don't have those schizophrenia, paranoid and disorganized and undifferentiated categories eliminated. So it's just one schizophrenia, but they've sort of given other dimensions in terms of how severity of the symptoms is there. So it makes it more, I guess, simple to deal with. So like it says here that the boundaries between different categories are more fluid than really concrete. So one of the main goals that they always talked about for the last 10-15 years was to make it more dimensional in terms of how you diagnose people, rather than making it very categorical. You either have this or that. Here you sort of are on maybe a spectrum. You can have major depressive disorder, and they've clarified what mild means, what moderate means, what severe means. In the past, it was basically based on your judgment, or what the patient tells you. Same thing for the alcohol use and benzo use and opioid use. They've really nailed down what is severe, what is mild, what is moderate. So it's very helpful in sort of making it more objective. So the descriptions are more accurate, I guess, to make the diagnosis more valid. And they've tried to harmonize with ICD. ICD is the system used worldwide. Even here, the billing department uses ICD. We use DSM. So there's that sort of disparity. But they've tried to make it more homogeneous so that there isn't a lot of separation from ICD, because that's what is used by the billers and other people. And that also makes our data more homogeneous and more in line with the international data. So like we said before, the main goal is to make it more dimensional than categorical. Do you sort of get it what I mean by categorical versus dimensional?
Yeah.
What that sort of simple, signifies. So it sort of helps us capture the sort of the sharing of symptoms between different disorders a little better, because you can have one and this other. It's not one or the other. So there's one and the other. And they're saying that this is a living document, unlike our constitution. So you can change it, and so they'll keep doing online revisions. And that will be sort of incorporated into the future DSM, whatever versions they come up with. Whenever they have new research findings in neurobiology, genetics, and they'll include it in that. So I think that makes it better for us, that if something changes down the line, they'll make changes there. And then the indicators they've used in this is a long list of what they've gone by to make the DSM-V. They talk about neural substrates, family traits, genetic risk factors, environmental risk factors, biomarkers, temperamental issues, course of illness. So I mean, this is a pretty comprehensive way to look at disorders. So definitely DSM-V is a step up. It's not a huge step up, but it's definitely a step up from the DSM-IV. So it begins with, like we talked before, from the basic neurodevelopmental disorders like autism, ADHD, then moves on to schizophrenia and psychosis, and then to anxiety and bipolar disorders, and then finally to the diseases like dementia. So as you'll discover, obviously the ADHD presents when you're younger. Same thing with autism and conduct disorders and some of the personality features. And then with schizophrenia, the presentation is usually when you are in your teens, late teens, and early sort of adulthood. And then the anxiety and bipolar disorders present later. And same thing with depression. So most people, have those diseases develop in their 20s and 30s, and then obviously dementia comes later in life. So that's how the DSM is sort of organized. They've given a lot of consideration to cultural issues. Many of the mental disorders are defined culturally, socially, um, and they present differently in different cultures. Our experience when we grow up makes things different for a lot of people, so we have to keep those things in mind when we diagnose people. And so they have talked a lot about cultural formulation, and they have given a lot of stress on the cultural issues. And one of the reasons is that there are many illnesses that sort of may be normative in certain cultures, and certain symptoms may be normative in certain cultures. There are certain religious groups, they do certain things certain way, but that's normal for them. We can't call them an illness because that's how people have grown up. There's I remember training. We had a patient who talked in tongues. I don't know what talked in tongues means. Later on, find out there's this Pentecostal church where they talk in tongues. You don't have to be, and you can have psychosis independently of that too, and you could talk in tongues. And similarly, in traditional cultures, Hispanic culture and Asian cultures, things are viewed a little differently than in Western cultures. So you'll have, I guess, lecture on cultural psychiatry too in the future. So we have to be aware of those things when we make a diagnosis. And then, certain cultures also make you more susceptible to certain illnesses. And that also is important. And how our family responds to things, how our culture responds to things is important in psychiatry more than anything else. Certain traditions can contribute to stigma as well. As you'll see, certain people from traditional cultures in some foreign countries here, when they come, they don't view mental illness the same way as we view mental illness in America here. And so you'll find a big gap in sort of accepting mental illness. So you have to sort of give a lot of psychoeducation to certain people regarding what psychiatric illnesses are. And certain cultures don't want to use Western medicine. They want to use their complementary medicine systems, which sometimes is acceptable, but most of the time is not. Because a lot of the patients we encounter in the hospitals are not the ones who can be treated with complementary systems of medicine. They need what is acutely needed from our system here. So you have to make sure that you have to understand and respect a culture, but also make sure we provide the right kind of treatment to people who don't understand what psychiatric treatment is about. And then there are certain cultural traditions in terms of how they accept treatments, and sometimes you have to involve more family in these patients, and in others, people don't want their family to be involved. There's certain independent individuals, they just want to get treatment by themselves, and others, they want the family to be involved more. So it becomes our job to make sure that we sort of try to figure out how far do we want to go to involve the family. And also, culture also affects how we view the patient. The way the culture that he was raised in may be different from the culture you were raised in or I was raised in. So when we look at the patient, we look at it differently. Of course, this gets sort of normalized as we train. After 4 years of training the same way, we probably will become the same way. But if you ask me how I viewed psychiatry maybe 15, 20 years ago, will be very different from what someone else viewed psychiatry, someone who grew up in a different culture. I grew up in a different culture. And how we sort of treat certain behaviors may be different. But with training, hopefully, you sort of develop one way of doing things rather than different. But still, it'll come and you'll have counter-transference. You'll have when you see a kid who is being brought up a certain way, and you have certain parents, and then you have grown up in a different culture, so that will always be at the back of your mind. But hopefully, we can get beyond those and just make a more objective assessment of the patient. And there are certain gender differences. How different genders have different presentations of illnesses. And you'll find out when you are going to get lectures on depression, anxiety, that the rates of depression, anxiety are different in men and women, or at least seeking help is different. Women seek help a little earlier. Men delay getting help, or they don't get help at all. So that makes the statistics a little different. Women are known to have more anxiety disorders, and even depression rates are somewhat higher. So there are those gender differences which you'll encounter a lot, and it also sort of affects how we seek help. And then obviously there are certain hormonal disorders. Men can't have premenstrual dysphoric disorder. Men can't have postpartum depressive disorder. So those differences are obviously there. And then ADHD is different. How it presents in males and females. In males, it's more sort of combined presentation, more hyperactive. In girls, it's more inattentive presentation. So those differences are also there. And same thing for depression and anxiety in kids can present very differently in boys and girls. And even with postpartum depression, you'll see that the way depression presents in women who are postpartum is very different from the way the depression presents in someone who's not postpartum. And there's a high likelihood of bipolar disorder in women who present with postpartum depression. There's a lot of data on that when you're encountering postpartum depression, you should make sure that you really rule out bipolar disorder. And the way the sleep and energy change in postpartum depression is very different from the way sleep and energy changes in someone who's depressed in general. So DSM has all these specifiers and unspecified disorders. They did get rid of the NOS diagnosis, but they still have these unspecified diagnoses, but they've made it a little bit more clear on what unspecified means. Usually NOS, you could just give anyone NOS, because if you don't have anything else, you give NOS. Here they have certain criteria why you use unspecified. So as an example, if someone has depression symptoms, they last a long time, but you don't have enough criteria to meet for a major depressive episode, so then you can call it unspecified depressive disorder. And there's this qualifier of insufficient symptoms, and you can still use unspecified depressive disorder, but there's a certain guideline on how to do that. So same thing with other disorders. When you look at the mild and moderate and severe, especially in substance use, they have given certain guidelines what severe means. It doesn't mean if I'm drinking a fifth, I'm severe all the time. So there are other criteria that makes someone having a severe alcohol use disorder. It includes tolerance, withdrawal, and those criteria determine the severity more than anything else. And then the case formulation, you'll do a lot of case formulation in the future. We've talked about biopsychosocial, which you'll learn a lot more about that. So when you do case formulation, it's very different from giving history. You have to give sort of a story of the whole case, and you talk about predisposing factors, precipitating factors, perpetuating factors, protective factors. So these are the 4 P's you use when you are trying to formulate a case. And especially when you do the board exam or the CVV or whatever they call it these days. So you have to make sure that you think of the predisposing factors, precipitating factors, perpetuating factors, and protective factors. And DSM-V has included that. In the past, it wasn't really there. So now there's more focus on clinical case formulation. So this makes us makes our assessment more sort of comprehensive when we are trying to devise a treatment plan. And then they talk about what mental disorders are. Obviously a mental disorder definition that's pretty cookie cutter. It's a syndrome. There's disturbance in cognition, emotions, behaviors, and which causes dysfunction in psychological domain, biological domain, and developmental domain. And usually there's significant distress or disability in social, occupational, or other important activities. So if you have a symptom it's not affecting you, then you can't really diagnose a person with a mental disorder. If there's an expectable response, if somebody's spouse died, father died, mother died, if they're crying and depressed, so they'll have some grief. So you can't really call that a mental disorder unless it extends to a point where they're suicidal and their symptoms have gone on for a long time. Then obviously you call that depression. And there are certain socially deviant behaviors which do not qualify to be diagnosed as mental disorder. And then, the need for treatment. You'll encounter this a lot in your practice here. So you have to see if the patient really needs treatment. You have to think of how severe the symptoms are, if they're risky to themselves or others, and how disabled they are. And there's certain people, they might have a mental disorder, but you might not want to treat them. Hi, Dr. Wellen. So when you make a diagnosis, there are certain elements of the diagnosis. Obviously, the criteria are there that you learn, and then how severe the diagnosis, the criteria are, and if the full criteria are met or not. And if they're not met, obviously you go with the unspecified or other specified diagnosis. And so when you diagnose a person, the primary diagnosis is usually how the individual presents to you, and you can use the previous diagnosis as well. And then you can use the specifiers like in remission, full remission, which you will learn when you learn about individual disorders. And of course there are severity criteria, mild, moderate, and severe. So in the hospital setting, usually the principal diagnosis is the one they present with. Many times it gets a little complicated because there's the insurance reasons, and then there's how did they get certified when they got admitted? Did they get certified for substance use disorders? Did they get certified for a mental health disorder, which essentially is the same, but still the insurance companies differentiate whether you're admitting for alcohol use disorder or whether you're admitting for a pure mental health disorder. If they're suicidal, they want you to use like a depression as a primary. If they are not suicidal but they're drinking or using drugs, then they want you to use that. So many times you encounter those issues with utilization review when you put the primary diagnosis. So, but we try to use the one that we think is right. But then there's the struggle with the utilization department. And then you obviously use the provisional diagnosis if you feel that they're not meeting the full criteria right now, but they can meet those in the future. And all these DSM diagnoses have a certain number associated with them, which you really don't need to learn now, but as you learn about DSM more, you learn about the numbers. So right now you just want to learn the criteria and learn how to ask those questions, which I guess Dr. Welling is going to teach now about how to ask those questions. So that's it. Any questions you have?
Thank you.
Okay. Thank you.